So how do we avoid or minimize these situations? Again, this is for more for my medical colleagues. So having clear guidelines and policies for monitoring of that baby before they're born. You need to have clear guidelines on managing obstetric emergencies. So what happens if things don't go as per plan? Now, this may apply to a situation where they're trying different instruments to deliver a baby, or in the middle of a C-section, you find a mother bleeding. What do we do? How do we manage that situation? And also to the management of the baby once they're born, looking at staff training, education, resuscitation, and so on and so forth. We need to have clear documentation systems. We in our trust are very good at actually having multidisciplinary case reviews, particularly for those challenging cases. Get other opinions when you're in a difficult situation. Speak to your colleagues, speak to the MDT team, and see what can be done to help address the situation. All hospitals in the UK now have incident reporting systems wherein incidents which meet their threshold are reviewed, and I would hope that these are done in a transparent manner, and that perception, parental perception of hospitals hiding something is not actually true. Sometimes case reviews do happen externally as well when parents are not happy with what they've heard from a hospital. So having that open policy, open communication with the parents is of paramount importance. Okay, good. Right, we've got about 12 minutes. I just thought I'll just spend some time on a couple of cases that I have come across, and uh, just some food for thought. I don't think there is enough time to have interactive. I had initially thought maybe we could have an interactive session on these two cases, but maybe just some food for thought, and then we can spend some time answering your questions if you have any.
Just
Case
to
one.
jump in, Dr. Kariholu, don't worry too much if we run over by a few minutes. I'm sure people who need to race off can, and we can continue perhaps for a few minutes with your permission. So please feel free to go through these in detail. They look very interesting.
Okay, perfect. Thank you so much. No, I just didn't want to keep people waiting here if they had other commitments. So I will go through these cases. So case one was in relation to a baby who had cerebral palsy secondary to hypoxic ischemic encephalopathy or birth asphyxia. This mum came in with reduced history of reduced fetal movements in late stages of pregnancy. Uh, she was initially seen by the midwife at some time soon after midnight. And on her initial assessment, the midwife didn't feel that this mummy met the criteria to require a review with a doctor. She was then not seen until about 4:40. So now we are 4 hours down the line, and then underwent an emergency section at 5:30 in the morning because of concerning CTG. And there was also a note from the midwife assessment in between at some stage, which suggested some suspicious trace and the need for transfer. And this was discussed with another senior midwife, but apparently no one came back and did anything about it. So on the initial case review, it was felt that there was potentially a delay of 3.5 hours from the time of the note, and the obstetric expert felt that that was unacceptably long. And as I said, the baby was born with had hypoxic ischemic encephalopathy grade 3, which is the most sort of severe grade. And the questions, obviously, for us were could this delay have been avoided? And could the C-section have been done sooner? And did this delay cause or contribute to the complications, i.e., hypoxic ischemic encephalopathy in the baby. So I know you're not from a medical background, but for those of you who have come across birth asphyxia cases at this stage, what are your initial sort of thoughts? What should we be looking at when we review this case? What sort of information do you need? Would you need, or would I need, you think, in reviewing this case? Anyone can. I can't see hands, but you can shout or you can.
Dr. Kariholu, people can't speak on the presentation, but they can pop any comments if they want into the chat function. So if you're wanting to throw a few things out, throw it into the chat function, and obviously questions in the Q&A function. But it may not be quite so straightforward to. Oh, there we go. We've got a
There we go.
couple.
So arterial cord gases. So as we see answers coming in here, I'll probably just make a start there. So obviously you need to, this question is about a baby with birth asphyxia. So birth asphyxia is going to happen if something has happened before a baby is born. Although sometimes things go wrong at the time of birth, in which case the history is clear cut. But you would want to start before the baby was, so you would want to review the events before the baby was born. So reduced fetal movements could be significant in this case. Then the midwifery review and their findings, very, very, very important to look at those. As I said, I'm not an obstetrician, so in these situations, I would rely on my expert obstetric and midwifery input on the management of the mother up to the delivery. So they would review CTGs for me, for us as a team. They would look at the management of labor. They would look at the fetal well-being, and then tell us whether delivery should have taken sooner. So late decelerations, I can see some answers there. Late decelerations, CTGs, and so on. Yeah, so hydrocephalus, someone has made a comment about hydrocephalus. So hydrocephalus is a situation where the pressure inside the brain is very high because the ventricles, which are balloon-like chambers inside your brain, the fluid inside those ventricles is too much, more than what you would need. Perhaps not relevant to this case, but yes, it can be relevant to some other cases. So you want to know the events that led up to the delivery, which is where the obstetric and midwifery experts would be very handy. Then I factor that information and then review the baby's management and clinical condition right from the time they were born. A baby's condition is very useful because how much resuscitation they then need sort of indirectly tells me about the extent of birth asphyxia. So the baby responds very swiftly to brief sort of minimal interventions, then it's very unlikely for them to have sustained prolonged or profound hypoxia of any nature. But if a baby then needs prolonged resuscitation and their heart rate is very slow at birth or not present at birth, and it takes a long time for the heart to come back, then that tells me that the hypoxia is significant. Apgar scores give us some idea of a baby's condition at those time intervals. Again, something that we often look at, a baby born with very low Apgar scores, and especially if those Apgar scores remain low despite resuscitation, that tells me that the baby has had significant hypoxia. Cord gas is very important, as I said earlier as well, particularly paired arterial and venous gases. So if I have only venous gas, yes, useful, but in terms of classifying hypoxia into acute, profound, or chronic hypoxia, it becomes very difficult. Placenta is very useful because it can help us find out the reason why a baby is born in a poor condition. Then the clinical progression, how did the baby subsequently do? How was the neurology? How many days did the baby need to stay in the hospital? Were there any issues with sucking, feeding, baby's tone? Uh, all very important. MRI brain then helps confirm changes which may be related to birth asphyxia. Now, there are, as I said, some conditions, metabolic conditions and genetic conditions which can present like birth asphyxia. So MRI can be a very useful tool in those situations to differentiate between that neonatal encephalopathy, which is related exclusively to hypoxia or asphyxia, from genetic and metabolic conditions. And then finally, long-term outcome. Yes, some babies do have a degree of birth asphyxia, but then has that led to any long-term developmental concerns? In milder hypoxia, it doesn't. But moderate to severe, it does. So having that information is very useful for me. What did their 2-year follow-up show? What did their 3-year follow-up, 4-year follow-up show? Were there any concerns raised at the school about their educational needs, about their development, and so on and so forth? Are there any letters from pediatricians or neurologists that can help me actually with my report? So someone has mentioned neonatal hyponatremia. Yes, neonatal hyponatremia is a condition where your sodium levels in the blood are low. And hyponatremia, usually severe hyponatremia in the neonatal period, is seen in the first 24-48 hours in the context of maternal hyponatremia. So again, I had published a very brief case series of babies with very low sodium. The normal sodium levels are somewhere between 135 to 145. And if you have a baby with sodium level of 120 and below, less than 120, you need to be extremely worried. That group of babies can have seizures, they can have brain, sort of long-term brain developmental issues as a consequence. And from that case series, and again, my ongoing experience, most of these are because the mother has drunk liters and liters of water in labor, which has gone unnoticed. And even in today's day and age, with a mom physically present on labor ward or on the antenatal ward, you know, no one is going to actively monitor how much water or fluid she's drinking. So prescribed fluids is different, but drinking plain water without any sodium often gets unnoticed, and as a consequence, mother's sodium levels go down, and as a consequence, the baby's sodium levels are low, and this can lead to problems. Next case, before I answer the next question, is in relation to a baby who was born slightly prematurely, 4 to 5 weeks prematurely. And the parents had signed a document refusing consent for any vaccines or any medication because of some concerns about side effects in their previous children. But then this child, this baby girl, subsequently had issues with her development. She was non-verbal, remained in nappies, needed wheelchair, and was unable to attend school. So the parents had not actually um, known up until they received a letter from their GP saying that the baby girl had received amikacin or gentamicin, I can't remember one of them, in the neonatal period, which they were not aware of. Now, amikacin, gentamicin, they both belong to aminoglycoside group, which which is ototoxic. It can cause damage to the inner ear, and as a result, lead to hearing loss in babies. But then again, with the current monitoring guidelines and processes in place in all UK hospitals, this is a very rare situation. So I've not come across uh, gentamicin related hearing loss in any baby, because we actively monitor the drug levels in a newborn baby. But there were some other issues. It wasn't, my role as the medical legal expert in this situation was not just to look at the dosage of gentamicin. Did we give appropriate dosage? Did the baby receive appropriate dosage of gentamicin levels? Did the doctors then monitor gentamicin levels in the blood appropriately? And did they act on any abnormal readings? So my role wasn't just limited to that medical aspect. My role was also to look at the consent process here. Now, according to the letter of claim or letter of instruction initially, the parents had actually signed a document where they had refused any drugs. But on reviewing the notes carefully, they had said no to vaccination and vitamin K. They had not, there was no documentation of any refusal to any other medicines. Now, in parents' mind, that's, signing that document may have meant that they're refusing all sorts of medicines. But from a medical legal point of view, the documentation was only about vitamin K and vaccination, immunization. But gentamicin is not a vaccine, it's an antibiotic. And this baby was actually born in a poor condition clinically, and needed breathing support. So the use of gentamicin as an antibiotic was justifiable. So those are the issues that, you do need to actually review when or carefully review when you come across these cases. So moving on to the next sort of comment, I think it's about receiving instructions after obstetric and neuroradiology input. Yeah.
Well,
So
just if I can just jump in, Dr. Kariholu,
yeah,
because I think you've just come to the end of your presentation, if I'm
I
correct, and
think
have a few
yes.
more
So
questions.
yeah,
So
maybe we can. Mhm.
first of all, thank you very, very much for your time so far. I'm going to jump into a couple of questions now. There's a few on here and a couple on the chat function. But just to advise everyone, just before we begin, that our next webinar in the series is a spinal webinar on Tuesday, the 21st of April, relating to cauda equina syndrome. So check out the information regarding that, and we look forward to seeing you there. But yes, we have a question from Julie Sharp, who's asking, ideally, at what stage do you, and I would imagine potentially also neonatologists in general, but at what stage do you prefer to receive instructions? After obstetric and neuroradiology input and opinion, or would you prefer to be, I guess, earlier in that point? What's the correct point to instruct you?
So I would say it varies from case to case. If the issue is solely related to the management after a baby is born, then we don't, I don't need an obstetric input there. But if there are concerns about the management of delivery, so maybe just specifically limiting myself to birth asphyxia cases, I would need an obstetric opinion, because establishing breach there is outside my area of expertise, unless any sort of breach has happened after the baby is born in terms of management and so on and so forth. But with birth asphyxia cases, I would say having an obstetric opinion is very important, crucial actually, for me to actually say anything. Um, um, with other cases that are more or less related to how the baby was then managed on intensive care, I don't really need obstetric input. And if I do feel when I receive the letter of instruction, that's something that I do make clear to my team, that look, this is what I would also recommend an opinion from an obstetrician or a neuroradiologist or an audiologist and so on and so forth. And I start reviewing the case whilst I sort of
Thank
wait.
you very much. So moving on, Katya Robbins has asked, what may cause a significant bleed on extubation?
So on extubation, many different reasons. It depends on when the bleeding has happened. Now, if a baby has, are we talking about bleeding inside the lungs or in the brain?
Well, I'm not sure if Katya An
Okay,
oral
oral
bleed.
bleed.
There
So
we go.
inside the mouth. So if it's a small amount of blood that the team notices when the endotracheal tube is out, that's most likely traumatic, because endotracheal tube is made of plastic and that can cause trauma. But sometimes for babies, very sick babies who've been on a ventilator, on a breathing machine, after you take them off the breathing machine, i.e. the tube comes out, sometimes the blood vessels inside their lungs can actually rupture. So there can be capillary rupture because of various physiological changes. So sometimes that can lead to that. But often, if it's just limited to their oral cavity, it's trauma.
Thank you. We have a question here from Ewan Kearney, who's asked, the guidelines for managing difficult airways in neonates were created in October 2020. So what approach would neonatal experts such as yourself, take in terms of establishing liability in cases that predate the guidelines?
So predating those guidelines, that it would, yeah, again be very difficult. So the approach that I take is for any case that predates any guideline or national recommendations would be for whatever evidence or guidelines was available at that time. So I would always look at what was available at that time. Did the hospital have any local guidelines or policies? Did they have any escalation policies? So difficult airway is a very specific example, and now it's been increasingly recognized nationally as an issue. But yeah, prior to 2020, so what did they have in place? How would they escalate if an individual wasn't able to intubate a baby? Did their guideline actually suggest calling an anesthetist or an ENT specialist or whatever? So you would then look at their local policies and guidelines.
Brilliant. Thank you very much. Cleo Brandt has asked, might there be a breach of duty in failing to diagnose hip dysplasia during a neonatal check?
Yeah, so again, in my experience, hip dysplasia is one of those conditions which should be obvious on newborn examination. So in my opinion, and those cases that I have seen, if you know, so those cases came sort of presented as a 1 year old or whatever, 1.5 year old with difficulty walking and then needing surgery. So it was very obvious that it was missed. So I would say yes, it's a breach of duty if we missed hip dysplasia, as opposed to some other newborn conditions. As I said, typically heart conditions may not be obvious at birth, can be missed easily, but hip dysplasia shouldn't be missed. And if you missed it, then it's breach of care.
Thank you. Jamie Swain has asked, it seems like the guidelines are clear as to how quickly decisions should be made with immediate neonatal care and how long a C-section should take. Are there specific guidelines for how quickly the decision should be, made to proceed to a C-section? Although I'm not sure whether this would perhaps be more an
Yeah,
obstetrics related
this is more
question.
an yeah, but there are guidelines. Yeah, I can tell you that there are guidelines for that.
Fabulous.
Yes.
And just finally, the last question we have today is from Ian Kerwin, who's asked, what is the significance of providing therapeutic hypothermia early in HIE-based injuries?
So the basis rationale behind using therapeutic hypothermia or cooling treatment is to reduce the secondary aftermath of hypoxia. So it doesn't reverse what has happened. It can't do anything about what has happened. But what cooling treatment can do is prevent what we call secondary injury, so the aftermath of hypoxic, and based on the studies and evidence available so far, that 6 hour period is very critical. So for the cooling to actually make a difference and reduce or minimize the impact on the brain, it has to be started within 6 hours. People have looked at 12 hours window, 24 hours window, so on and so forth. But that 6 hour window is the most sort of crucial bit, which is why it has to be done or started within those 6 hours.
Brilliant. Well, with that, all I have to do is to say thank you very much, Dr. Kariholu, for your time today and for answering the questions. I think on behalf of all of us, We found that incredibly interesting. To remind everyone that the recording as well as the slides will be made available in the next couple of days. And just lastly, again, thank you very much for your time and joining us at this InNeg event. And we look forward to seeing you at our next one on Cauda equina syndrome. So have a great day and wishing you all well.